During deep, slow-wave sleep, the brain's glymphatic system actively clears toxic metabolic waste. This is the vital physiological window where harmful accumulations, including beta-amyloid proteins, are flushed away from neural tissue. Because the failure to clear these proteins is heavily correlated with Alzheimer's disease and cognitive decline, clinical practice has traditionally treated sleep deprivation as a primary modifiable risk factor. We operate on the assumption that less sleep inherently equals more cognitive damage. This flowchart details the 2020 China Health and Retirement longitudinal study, challenging that linear assumption. By tracking a nationally representative sample of 15,526 adults, researchers mapped cognitive health. To guarantee accuracy, they applied strict exclusion criteria, removing participants with missing cognitive function metrics. For respondents sleeping 4 hours or less, the cognitive function beta coefficient was negative 1.85. Yet, for those sleeping 10 hours or more, the coefficient drops to negative 3.01. Extreme long sleep's destructive impact on global cognition is nearly twice as severe as insomnia. This forces a reevaluation of how sleep duration impacts brain health. We have to identify the distinct physiological mechanisms driving cognitive decline at these opposite extremes of the sleep spectrum. Extreme long sleep is not a benign feature of aging. It is a potent predictor of cognitive decline, demanding the same level of clinical intervention we typically reserve for insomnia. This graph illustrates the relationship between sleep duration and cognitive health. Across multiple tests, the data forms a nonlinear, inverted U-shaped curve. The highest point of global cognitive preservation sits in the 7 to 8 hour window. This is the physiological optimum for the aging brain. However, as duration moves away from this apex, either too short or too long, the decline is not uniform. The brain's distinct functional domains degrade at highly unequal rates. Notice the trajectory of the green line, tracking episodic memory. It declines, but remains relatively shallow. Now look at the red line, representing mental intactness. At the extreme ends of the sleep spectrum, this domain suffers a much steeper, more aggressive collapse. Mental intactness is a critical composite metric. It evaluates executive function, attention, and visuospatial skills, the critical abilities required to sequence tasks, process real-time information, and maintain attention. When this specific domain fails, the downstream consequences are immediate and practical. Older adults lose the capacity to safely manage medications, navigate public transit, or remember if an appliance was left on. An unstable sleep architecture first compromises a patient's executive autonomy. This creates a systemic safety risk in their daily life that standard episodic memory tests alone often fail to detect. The mechanisms depend entirely on which side of the sleep curve a patient occupies. On the left side, characterized by sleep deprivation, the damage results directly from neurological stress. Insufficient sleep triggers hormonal dysregulation, driving up cortisol levels. This chronic elevation exerts highly specific neurotoxic effects, accelerating the degradation of synapses in the hippocampus. On the right side of the curve, the pathology shifts. Prolonged sleep does not directly poison the brain in the same manner. Rather, it acts as an active biomarker signaling underlying systemic decline. Extended sleep duration is tightly linked to elevated inflammatory markers, specifically C-reactive protein and metabolic dysregulation. The body stays in bed because it is fighting chronic disease. This pathology is compounded by specific social frameworks, creating a phenomenon we can call the long sleep paradox. In many traditional Chinese cultural contexts, prolonged rest is incorrectly promoted as a health benefit for the elderly. When families encourage older adults to stay in bed under the guise of resting, they inadvertently reduce their baseline physical activity. This well-intentioned cultural emphasis drives behavioral isolation and a highly sedentary lifestyle. Clinicians must learn to differentiate between the direct interior neurological damage inflicted by short sleep and the systemic inflammatory decline signaled by long sleep. Simply treating insomnia with pharmacotherapy, like prescribing zolpidem, often fails to provide a sustainable solution. Chemical sedation induces unconsciousness, but it does not structurally repair the underlying sleep architecture. Instead, cognitive behavioral therapy utilizes sleep restriction therapy. This is a mechanical behavioral intervention designed to artificially force the body's homeostatic drive to sleep. Sleep efficiency is calculated by dividing total sleep time by total time in bed. If a patient is in bed 9 hours but sleeps 6, efficiency is poor. Sleep restriction therapy strictly shrinks time in bed to match actual sleep, rapidly driving the ratio upward. This induces mild sleep deprivation in the short term. Clinicians then titrate the time in bed upward in small weekly increments, maintaining that high efficiency while slowly consolidating fragmented blocks of sleep. By strictly limiting a patient's time in bed, we paradoxically rebuild the neurological drive required to reach the 7 to 8 hour cognitive apex, all without relying on sedatives. The data establishes a strict bimodal risk. Insomnia accelerates direct neurological damage, but hypersomnia stands out as an even more severe predictor of cognitive destruction. Preserving executive function and mental intactness requires actively moving patients out of these destructive extremes and into the physiological optimum. Looking closely at this graph, the objective becomes clear. Mechanical interventions like sleep restriction therapy are tools to pull patients away from pathological edges, whether reducing the inflammation of long sleep or the neurotoxicity of short sleep, anchoring them precisely at the curve's center. Modern medical practice must move beyond chemical sedation and address the behavioral and architectural realities of how we rest. Protecting the aging brain requires a sophisticated understanding of the sleep curve. Our focus is the active engineering of the precise architecture that sustains the mind.